Hey everyone, this is Chris Romeo with MedAxiom. We're going to give this just a minute to allow everyone to log on that's registered. So please be patient. We'll be with you in just a minute. Okay, while folks are logging on, we're going to go through a few housekeeping items real quick before we get started. The first is in the chat. We're going to be putting today's presentation in there that you can download and share with any of your colleagues and coworkers that you may want to share this with. So feel free to download that during or after the presentation. Also, if you have any questions, there is a Q&A button at the bottom. And when you see that, you'll be able to click on that, add your questions. We'll be monitoring that throughout the presentation. And so any questions will be answered in the order that they come in. So please post any questions that you may have in that little section there under the Q&A section. Lastly, there is you can push the presenters off to the side if they're in your way. There's a button that you can just push that, but you can just go to full screen for this presentation as you see fit. So with that, we're going to go ahead and get today's presentation started. Today's presentation is sponsored by Edwards Life Sciences. The title of today's presentation is Integrating Multimodality Imaging in Aortic Regurgitation Assessment. We're going to have a panel of speakers, but today we're going to kick it off with Dr. Strom. So Dr. Strom, I'm going to turn it over to you and take it away.
Thank you everybody for joining me tonight, and I think you've got a really great presentation ahead of you. I'm going to start by talking about the status of aortic regurgitation in 2025 and where echo sort of fits into things. I'm an associate professor of medicine at Harvard Medical School and director of the Echo Lab at Beth Israel Deaconess Medical Center. And next slide, please. These are my disclosures. Next slide, please. And one more disclosure. Next slide. All right. So what about AR? AR in general, I would suffice to say that the actual prevalence is not well established because we don't do echoes on 100% of the population. And so therefore we can estimate what the prevalence is, but we don't really have a great sense of what the true prevalence actually is of the disease. That being said, what we know is that it's probably the third most common valvular heart disease with a lifetime risk of 13% in men and 8.5% in women. It's like male predominance. Older individuals in particular are likely to get it, and those who have bicuspid aortic valve present nearly 2 decades earlier. The progression is highly variable from individual to individual, but greater than 25% of those who are asymptomatic and have severe aortic regurgitation and LV dysfunction develop symptoms in the course of 1 year. And once you have symptoms, the annual mortality is 25% without intervention. So a pretty high number here. And just to remind people that cor bovinum is the definition, is what we used to call this, is a cow's heart. And that's because these hearts develop such profound hypertrophy, both from the volumetric load, but also from the hypertrophy load that and pressure load, that they end up being some of the most massive hearts we end up seeing. You want to go to the next slide, please? So why echo first? And oftentimes we default to echo because that's what's available. And in fact, actually, we know that about most of the country, 95% of the country, lives within 16 miles of a center capable of performing an echo. So this is a really widely available technology. It helps to assess the severity, the mechanism, the hemodynamic consequences, and associated pathology. And we can use that in serial exams to really evaluate how things change over time. The challenge with echo, of course, is that there's a fair degree of interoperability due to either acquisition or interpretation, but also there's not a single severity metric for aortic regurgitation, and therefore there's some overlap between those that we call moderate and those that we call severe aortic regurgitation, and so it makes it more challenging to decipher who in fact is really severe and needs further therapies. Of course, there is the option of being able to do a TEE, and you get a great look at the aortic valve leaflets and as well as the aortic annuals. But the TEE is, at the end of the day, an invasive procedure, and we would like to be able to evaluate this non-invasively, even though the risks for TEE are very small. Next slide, please. So there's a number of different ways to evaluate this on echo, and this is just going through a couple of them. Of course, people can use the proportion of the jet width to the LVOT diameter, and if it's greater than or equal to 65% of the LVOT, this is specific for severe AR. But of course, if the AR is eccentric, it may underestimate, and if it's transient, it may overestimate this. And of course, big people have big LVOTs, and so is largely dependent on the LVOT size. Now, vena contracta is a attractive measure because at the end of the day, it's the narrowest jet width that we can measure. The definition of severity is greater than 0.6 centimeters, but it is impacted by the jet direction. If it's very eccentric, you may not be able to measure an accurate vena contracta. And what do you do with multiple jets? What if you do if you're off by 1 or 2 millimeters? That can be really problematic and change the grade of the AR in that setting. So as we do with the MR and TR, we could look at the piezo radius, but there's not a real great definition that we have that's well agreed upon in the literature about what actually constitutes a severe definition for severity. There's obviously the same problems with multiple jets, and there can be constraints that are imposed by the aortic wall that may confine the piezo shell to a certain angle. The flow convergence can be non-hemispheric as in MR and TR, and therefore we are assuming circularity of the flow convergence region, but actually that's a false assumption. So getting around that, we could use 3D vena contracta area to really be able to assess what is the smallest area. The definitions of severity are largely borrowed from other valvular heart diseases, but also this can still be problematic with dynamic jets, and the Doppler area can appear larger on 3D vena contracta area, so-called blooming artifact, which can interfere with our ability to be able to assess this. Next slide, please. So what about Doppler? Well, we could use our spectral Doppler tracings, and we could look for flow reversal in the descending thoracic aorta. If it's present, which means that it's greater than 20 centimeters per second at the end of diastole, that is a specific sign for AR, but a severe AR, but is not sensitive. And you can see it in other settings as well, with AV fistula and with sinus of valval ruptures. There's a component that depends on aortic compliance. And with acute AR, you may not, in fact, have that adaptation to and change in compliance to allow for holodiastolic flow, and therefore the flow that you see may not be holodiastolic. The density of the jet, so if the continuous wave jet is very dense, that suggests that there's more severe, but there's a lot of overlap between moderate, severe, and the central jets can appear denser as well. Pressure half time, certainly it's very short, so should suggest that the AR is more severe, particularly less than 200 milliseconds, but really requires a lot of assumptions. It requires that you're parallel with the AR jet, and it's impacted by both the LV and aortic compliance as well as the systemic vascular resistance, and is maybe less useful in chronic aortic regurgitation. Quantitative methods there are many of them, as some of them like EROA area or regurgitant volume and fraction are derived from PISA or other estimates. This can still be problematic with multiple or eccentric jets. There's some limited validation data, and some of the assumptions we make about the PISA, for instance, the flat plane in which it goes against may be violated. The also issue here is that if you have a very small flow convergence, small differences in your measurement could lead to large errors. So really challenging overall. Not listed amongst these is of course the stroke volume method, which is another useful parameter. Go to the next slide. So all in all, what I've presented to you is each individual parameter has its strengths and weaknesses. And so we put it together in the guidelines using specific criteria for severe AR. And if you have specific criteria for severe AR and you have 4 criteria met, then you have severe AR. If you have specific criteria for mild AR and 4 are met, you have mild AR. But there's this whole lot of things in the middle. And it becomes very complicated because you may have some of these measures, but not all of these measures. So it's complicated to interpret. It's missing key considerations at the end of the day, including things that are relevant, like blood pressure. If the patient is very hypertensive and the AR appears more severe, it may be in part due to the blood pressure. LV function and size, LV is dilated, but the AR is called as moderate. Could that actually be severe AR that is somehow being misclassified as moderate? It doesn't tell you about the etiology. What do you do with mixed aortic valve disease, AS and MR, or AS and AR, and then concomitant valve disease is always a challenge. So there's a lot of these conditions where we might consider broadening this. So if you want to go to the next slide. You are not alone if you think this is hard. This was a survey that was sent out, a global online survey to 100,000 MDs and sonographers across 104 countries. And the most common response in terms of the most difficult valve to quantify was aortic regurgitation. And mostly people were using visual interpretation of the color check, with some looking at retrograde flow in the descending thoracic aorta. But people recognize that eccentric jets and poor image quality can really reduce the quality of this. So if you want to go to the next slide, this is increasingly a challenge. And of course, now we have these questions about how often we should be repeating the test. In those who have progression, what determines that person's risk of progression? And there's minimal abilities to be able to predict those who are likely to be able to progress versus not. Some of the same considerations inherent here. I'll go to the next slide. Next slide. So why don't we just wait till symptoms? Well, the problem is that 90 cardiologists, when surveyed, wait for symptoms. 91% said that the evidence that they look for in order to refer the patient for surgery is ultimately the development of symptoms. And that's well and good, except for the fact that symptoms are very difficult to tease apart. In an analysis and Optum data set, 1 in 4 symptomatic severe aortic regurgitation patients, these are patients who were already symptomatic, were treated within 1 year of diagnosis. So even with symptoms, patients are often not referred for consideration of treatment. The unadjusted mortality of those with symptomatic severe aortic regurgitation is substantially lower than the untreated population, and a lot of it depends, in fact, on the primary cardiologist. What we know is that if the overall cardiologists who refer more frequently for surgical aortic valve replacement had an improved survival amongst their patients, and survival was actually 23% higher in those referring the most. And there was an interaction with ejection fraction. With those who had an ejection fraction of less than 35%, they were substantially more likely to refer than those who had an ejection fraction that was only moderately reduced. Next slide, please. And of course, what we know is that regardless of whether or not the EF is less than 35% or greater than 50%, greater than or equal to 50%, in both of those cases, the surgical fix ultimately improves survival. But at the end of the day, we also know that EF is a key modifier of these outcomes. So intervening before the EF becomes less than 35% is ultimately going to potentially have the best benefit for those patients. So the ACC AHA guidelines currently have a class 1 2A recommendation for AVR for asymptomatic AR when the EF is less than or equal to 55%, but the LV cavity is dilated. So either the systolic dimension is greater than 50 or 25 millimeters per meter squared, or dilated. Next slide, please. And one of the questions is that too late, in fact? One of the issues is that these surgical thresholds were based on studies from the 90s and 2000s, but nowadays the AVR mortality rate is extremely low. It's about 1.1%. And in fact, we know that the risk is not some threshold that you fall off, but is in fact continuous. And so these are a number of studies that are looking at this, but you can see that in fact, actually, if you were to use other cutoffs of increased risk, such as a global longitudinal strain worse than 15%, or a indexed end systolic volume greater than or equal to 45 milliliters per meter squared, or an EF less than 60%, of those who have a 3 to 4 plus aortic regurgitation, only 20.4% met current class 1 indications, but at least 63% had one marker of early dysfunction. So there are many people who are sort of just on the line of decompensating further, and maybe we should consider early referral in that population. Next slide, please. And if we look at how that equates to outcomes, we can see that as you have the increased number of criteria for LV dysfunction, even if you have not yet met the recommendations for class 1 or 2A recommendations for repair, there's a stepwise increase in mortality risk with more signs of LV dysfunction. So this really is a key to identify these patients early and get them referred early so that they don't show up with an EF of less than 30%. Next slide, please. So in summary, AR is common, more common than thought, and it's high risk. Echo is a first-line diagnostic modality, but requires an integrative method, and there are a number of other challenges, and we'll speak to some of the other multimodality imaging here. Progression can be variable and sporadic, and even with symptoms, AVR rates remain low, despite the evidence of benefit, regardless of what the LV function is. Current guidelines are based on historical thresholds and ultimately may be limited to identify at-risk individuals. So refer early and often. A multimodality imaging approach is critical at the end of the day to establishing the diagnosis and severity in a timely fashion and referring people appropriately. Thank you very much. And we'll now turn this over to Dr. Xu to present the next aspect of the talk.
Great, thank you, Dr. Strom. Thanks for bringing to light these important limitations of transthoracic echo. My name is Jennifer Xu. I am assistant professor at the University of California, Irvine, and a structural and interventional echocardiographer at my institution. So I am going to talk to you all about selection of alternative imaging modalities in evaluating aortic regurgitation, as well as serial imaging in guiding timing to surgery. Next slide. These are my disclosures. Next slide. Next slide. So a big question is what to do when you have a patient with discordant values on echo. Some of the markers are in the moderate range, and let's say some of them are severe, or your image quality is so suboptimal because of an eccentric jet. The official recommendation from our societies to escalate to CMR is where echo is inconclusive or further evaluation of AR severity is warranted. And that leaves it quite open to the ordering provider. But I find where truly cardiac MRI shines is in the quantification of aortic regurgitation. It has superior reproducibility to echo. It can directly quantify stroke volume and regurgitant volume using phase contrast imaging. How you do it is that you put the region of interest at the level of the sinotubular junction and perpendicular to the aorta and get the total forward volume, back volume, and calculate regurgitant fraction that way. Next slide. Next slide. An important thing to note is that the cutoffs for echo and cardiac MRI are quite different. Whereas the regurgitant fraction is equal to or greater than 50% on echo for severe aortic regurgitation, on cardiac MRI, the threshold is between 30 to 40. Next slide. And this is because of a number of studies that have been published recently where using a regurgitant fraction cutoff value of 33% correlated better with symptom progression or need for aortic valve replacement. And this is becoming a source of contention because the echo cutoffs for AI and MR are the same. They're both regurgitant fraction over 50% and regurgitant volume over 60. However, aortic regurgitation and MR are completely different diseases. AI is a disease of pressure and volume overload, whereas MR is a pure volume overload condition. And it would intuitively make sense that smaller amounts of AI than MR might lead to adverse left ventricular remodeling. Next slide. So here is an example where MRI was beneficial in evaluating a patient. This is a 60-year-old male who had a David V procedure. This is my error, it's not a Bentall. The root was replaced, but the valve was spared. And you can see that the patient has a very eccentric AI jet directed towards the anterior mitral valve leaflet. The cusps appear to be very shortened and thickened. And in eccentric jets, as Dr. Strom had mentioned, the echo parameters such as jet width and jet area don't necessarily hold. Next slide. So the patient got an MRI, which demonstrated a regurgitant fraction of 50%, which was consistent with severe aortic regurgitation. This patient ended up getting referred for a reduced sternotomy and got a new aortic bioprosthesis. Next slide. Now, what about CT? CT is less recommended as a first-line imaging tool for assessment of aortic regurgitation severity, but it is actually feasible to measure. These authors, what they did is that they reconstructed images of the aortic valve at multiple cardiac phases in 5% steps. Through short-axis images, they were able to trace the exact regurgitant orifice area produced from two orthogonal longitudinal planes. And due to their success in their image acquisition, they were able to show measurements consistent throughout all of diastole. Now, using CT in this way has a number of limitations. It does tend to be overestimated compared to PISA-derived EROA by TEE, and it would be a more difficult method if the jet is poorly visualized or the cusps have too much calcification in order to distinguish between what is jet and what is cusp. But if you don't want, and also if you don't want to excessively irradiate the patient by looking at the entire cardiac cycle, it would not be the best option. So truly, CT is not recommended for this purpose, but is quite essential in assessing the underlying etiology for aortic regurgitation in cases of disorders of the root and ascending aorta. Next slide. This is an example of a patient who benefited from CT. It's a 71-year-old male with shortness of breath. And as you can see in the peristernal long axis view, he has a very dilated aortic root and ascending aorta measuring 5.4 centimeters. And he has severe wide open aortic regurgitation with a dissection flap that is visualized at the level of the root. Part of the flap is interacting with the aortic valve leaflets, obstructing its closure. Next slide. The patient underwent a CT, confirming a type A dissection that starts at the level of the sinuses of Valsalva and extends along the thoracic and abdominal aorta and goes all the way down to the iliacs and up to the brachiocephalic. This patient underwent a modified Bentall procedure with root replacement with a bioprosthetic valve sewn inside of the graft. Next slide. So now that we have utilized our alternative imaging modalities to establish that regurgitation is severe, the next question is, when do we operate? On this pressure volume loop, you can see that in aortic insufficiency, a lot of blood comes back into the left ventricle. So the stroke volume and the end diastolic volume rise. The left ventricle compensates by dilating and increasing contractility. But over time, chronic volume overload will lead to wall stress, loss of contractility, and falling stroke volume. And so the key here is really to intervene before the left ventricle fails, which is why the end systolic dimension has emerged as a very important marker to follow in chronic aortic regurgitation. Next slide. We started by noting that there was a correlation of LV end systolic dimension of greater than 50 millimeters that was tracking with particularly poor outcomes. Nowadays, we routinely index this value to body surface area because of the circulation paper in 1996 that pointed out a significant gender discrepancy in our patients. They noted that the post-op survival of patients undergoing SAVR was significantly in favor of men. It seemed like at the end of 10 years, men were surviving almost double the rate of women. And it seemed like that on further analysis, that was because the women were of smaller size. They did not, at the time of surgery, achieve this end systolic dimension of 50 millimeters. They were not getting surgery until they presented with quite advanced symptoms. And so this has provided the basis for the current guideline recommendation for surgical intervention at this threshold of 25 millimeters per meter squared. Next slide. Recent data suggest that there seems to be a mortality drop-off at even lower thresholds than this. These two studies show an increase in mortality at a threshold of greater than 20 millimeters of meters squared. Next slide. The other thing to mention is that should we really be relying on the linear measurement of end systolic diameter? This is just a single linear measurement and doesn't give a complete picture of LV size, especially in the context of the asymmetric enlargement that you're typically seeing in aortic regurgitation. So LV volumes are truly more ideally suited to assess how the left ventricle is changing. This paper shows a cutoff of an LV index volume of 45 milliliters per meter squared as associated with increased mortality. But the challenge is really how to measure these volumes. Since 2D echo is notoriously terrible at measuring LV volumes, especially if you have poor image quality or the image is foreshortened, echo enhancing agents can be helpful, but they don't necessarily they aren't necessarily magic. 3D echo is better, but also highly dependent on image quality. So the gold standard for reproducible LV volumes is accomplished with cardiac MRI using breath hold imaging, averaged over several cardiac cycles, and using Simpson's rule for adding each slice volume. Next slide. In my last slide, I have listed the guidelines that our societies recommend to formally intervene, and that includes symptomatic, fallen left ventricular ejection fraction, progressive decline in LVEF to 55 to 60% on 3 serial studies, cutoffs on the studies I've just mentioned on a LV end systolic dimension of greater than 50 and greater than 25 millimeters per meter squared. If the patient's LV end systolic dimension is greater than 20 millimeters and is low risk, it is listed as a 2B guideline in European guidelines, and as well as in addition to those who are undergoing other cardiac surgeries. Accurate serial assessment of the extent of LV remodeling is truly essential. The recommendation that the LVF is declining to 55 to 60%, that is not an easy in our clinical practice to really track. So my clinical practice has been to start with transthoracic echo, and if there's poor endocardial definition or image quality is suboptimal, I don't hesitate to escalate to CMR if needed. And for women, as they are known to have worse outcomes, I have a lower threshold to progress to serial images if I have concerns about progression. Next slide. And that's the end of my talk. And next, I would like to turn it over to Dr. Milind Desai, who has published a tremendous amount about novel markers about progression in the field. Welcome, Dr. Desai.
Thank you very much. Hello, everybody. Thanks for the invitation. My name is Milind Desai. I am at the Cleveland Clinic. I'm the vice chair here in Heart Vascular Institute, and I also co-direct our cardiac CT MRI labs. Next slide, please. So these are my disclosures. Next slide. Next. So my job is to convince you in 8 minutes that cardiac MR plays a pivotal role in evaluation of aortic insufficiency. I like to divide CMR into 3 stories. One is the valve story, one is the aorta story, and the other one is the LV story. So we'll address that. But what are the guidelines say? Class 1 indication is if you have a discrepant echo, then TEE, CMR, or heart catheterization are indicated for assessment of LV systolic function. That's class 1 level of evidence B. If you have somebody with a bicuspid aortic valve or a suspected aortopathy, then tomographic imaging, be it CMR or CT angiography, is recommended for precise assessment of this aortopathy. So with that as a background, let's go to the next slide as we look at things. I'll set up with a case, a 41-year-old male, active marathon runner, no significant history. 10 months ago, he actually ran a marathon 50 miles per week and routinely runs 50 miles a week. PCP heard a murmur. The story goes transthoracic echo, bicuspid valve, moderate to severe AR, and mildly dilated aorta. At that time, there was also a cardiac MR done. And after a discussion, things were moderate, severe. Life goes on. Let's not do anything. Remains asymptomatic, but then comes back for a follow-up cardiac MR. Next slide. On the CMR measurements, now the EDV index is 194. EF is 53. Please go back. Diana? Can you go back one slide? Yeah. Confirmed Sievers bicuspid aortic valve, severe eccentric AI with holodiastolic flow reversal of the aorta. Long story short, patient had severe AR with severe LV dilation, and it was time for surgery. Things progress really rapidly. So how do you handle AR quantification using CMR? Typically, it is done using phase contrast cardiac magnetic resonance imaging, which measures forward volume, regurgitant volume, stroke volume, as well as regurgitant fraction. it is absolutely important, and I'll talk about it in a second, where the plane of imaging is prescribed. You have to you have to assume you're wrong and work your way backwards. Think about all these errors: translational valve motion, arrhythmias, prominent LV trabeculations. If you have multiple valve lesions or intracardiac shunts, phase contrast may be a problem. Dilated aortic root can result in problems. Next slide, please. Next slide. So if you are doing a serial phase contrast measurements, serial CMR, it is absolutely important that you look at the past study and where the plane of phase contrast assessment was done. This is a study we published many years ago. The values of regurgitation fraction are different depending upon what part of the ascending aorta you are imaging. So if your technologist is just a bit cavalier about it, you may have different values that may potentially not help the patient, and somehow you may end up hurting the patient. So this is absolutely important to realize and recognize. Next slide. Other thing, as I alluded to, similar to echocardiography, this is a paper that was published looking at the role of hollow diastolic flow reversal. If you are able to document that in CMR also, that has a very high predictive value for severity, for the fact that this could be severe aortic insufficiency, similar to echocardiography. Next slide. Again, this was mentioned. One thing I'll reiterate again, the numbers between echo and CMR are not interchangeable. Regurgitation fraction is 50%, more than 50% in echocardiography, more than 30 to 40% in cardiac magnetic resonance. Okay, and plus the hollow diastolic reversal tends to be similar, but this is absolutely important to keep in mind. Next slide. Again, then moving on to the aorta story, precise measurements, because sometimes the worst thing that can happen is you fix the aortic valve and forget to replace the ascending aorta. That could be aneurysmal. So it is absolutely crucial. Every BAV at least once should have a tomographic scan to make sure there is nothing going on in the aorta. Now, next slide. So now moving on to the LV side of the story, remodeling occurs in chronic aortic insufficiency. And this is work that has been published, which showed thresholds 129 mils per meter square for end diastolic volume, 43 to 45 mils per meter square for end systolic volume, strain utilization, ECV, all these things have shown the cutoffs that are associated with adverse outcomes. Next slide. Again, this is beautiful work from Houston Methodist, which they developed ROC curves and specific cut points for AR volume, AR fraction, the LV dimensions, as well as systolic, as well as LV volumes. And using these cutoffs, go to the next slide. There was demonstration of significant incremental prognostic value if you use these cutoffs to time surgery as well as to look for long-term outcomes. Next slide. If there is CMR, myocardial fibrosis cannot be far behind. So no scar is much better long-term than any scar. And ischemic scar is significantly worse than non-ischemic scar, which is worse than no scar. But as all of us know, there's a fair bit of heterogeneity in LGE assessment. So we need conclusive data, possibly multi-center prospective data. Next slide. ECV, interstitial fibrosis, extracellular volume. This is another thing that is routinely done in cardiac magnetic resonance assessment. And the worse your ECV, the worse your long-term outcomes. The higher your regurgitation fraction, the higher your ECV. So there is an association between the two. So remodeling does result in change in the interstitial fibrosis. Next slide. Feature tracking, again, global longitudinal strain, a lot of work has been done in echocardiography to establish thresholds. but similar smaller studies are emerging in the setting of cardiac magnetic resonance. And this is one study that I highlight where there were significant differences noted on feature tracking strain using CMR, and they were associated with the penalty of worse GLS, and feature tracking was associated with penalty of worse outcomes. Next slide. So again, we are living in the brave new world of machine learning, and using this in this very, very nice study, the authors identified using machine learning phenotypes that are associated with worse outcomes. So if you are an older patient, predominantly male with high scar and comorbidities with LV dysfunction, your outcomes are much worse compared to somebody on the opposite spectrum. Next slide. So to conclude, CMR plays a very important adjunctive role to echocardiography, but you have to understand its shortcomings and work around it. Important role to assess concomitant aortopathy, and there is an emerging story with CMR in terms of LV remodeling, fibrosis, as well as machine learning, AI. Like everywhere else, it'll help us find a higher risk prototype. Thank you so much. Next, I would like to introduce Dr. Beaver, who is chief at University of Florida. Dr. Beaver.
Well, thank you so much. It's a privilege to be with everybody this evening to bring a surgeon's perspective. Next slide. Next slide. So I thought we Dr. Zhu showed the guidelines, but just to go through it one more time, because this is what surgeons are going to be paying attention to. So Class 1 guidelines, symptomatic patients, of course, Class 1 guidelines, asymptomatic with depressed function. And then Class 1 guidelines, severe AR undergoing cardiac surgery for other indications. Next slide. And then the 2A indications, which importantly are the ventricular dimensions start to go large in asymptomatic patients and greater than 25 millimeters per meter squared. And we'll come back to this number numerous times. And then the other would be moderate AR at time of surgery. And then the next slide, the final would be the 2B indication for, as we mentioned, progressive decline on serial echoes or progressive increase in the left ventricular diastolic dimension of greater than 65. So next slide. So I'm kind of pinch hitting for Dr. Joe Bavaria, who many of you know. He's a great dynamic speaker and now a chief at in Philadelphia at Jefferson. But his question is really, are we really going to wait until patients have with asymptomatic severe AI have symptoms? Next slide. And his other comment is, we're looking at dimensions, linear dimensions, and as is shown elegantly by the panel, the CMR can show us a much better perspective on what the volume is. Next slide. And finally, the linear measurements for AI are based on older data, and again, the true extent is of LV volume is better imaged by CMR. Next slide. I wanted to go over, there's 3 major papers from 3 major centers that do a lot of aortic regurgitation surgery. The first one is a center from Belgium, and Dr. Jabreen El-Khoury is a phenomenal aortic valve repair surgeon. But what they did is they looked at 356 of their patients. They had 204 patients that had classic Class 1 indications, which I showed you, which are symptoms or LV dysfunction. Remember, 91%, according to Dr. Strom, of cardiologists are referring for symptoms. And then there's these group asymptomatic patients in the red box with Class 2A, Class 2B triggers, and there's another 79 without triggers. And let's just kind of see how they did in this study. Next slide. So those survival on the y-axis, years after surgery on the x-axis, and those with symptoms did worse. Next slide. And so it's obvious that if you have worse function, that you're not going to do as well. But do we really want to wait for symptoms? I think that's the million-dollar question. Next slide. And then those with worse function, if you wait till worse function, they did worse in long-term survival. And next slide. And that, of course, is bad, and we should be operating earlier. Next slide. This is getting down to that 25 millimeter per meter squared. The red line is less than 25, and the green line, it's kind of faint, is greater than 25. And you can see the survival is worse over time in this particular at this particular center in these patients. Now, the caveat is most of these patients got repairs, not replacement. But clearly, at least at this center in this series, waiting until the classic guidelines had a penalty. Next slide. And that's illustrated here. Next slide. And then here's survival according to the guideline triggers, which we've pretty much talked about. So waiting for class 1 triggers, waiting for symptoms, which according to Dr. Strom, 91% of cardiologists are doing, it may not be the right way to go. Next slide. So here's from this is from the Mayo Clinic. So we looked at Belgium. Here's Mayo Clinic with Dr. Schaff. And from the imagers, Dr. Maurice Enriquez Serrano. I think many of us remember when this paper came out in 2019. They looked at 748 of their patients that they were able to track. 361 had surgery, 387 didn't. Next slide. And kind of the central tenet of this paper is that there's a mortality penalty starting at 20 millimeters per meter squared. They started to notice increased mortality versus the classic guideline of 25. Next slide. And this is what it's illustrated. The top left panel A is less than 20. Survival in blue is patients that got surgery. The patients in red did not have surgery right away. The panel in B is 20 to 25, where they do a little worse. And the panel in C is waiting for the classic guideline of 25. Millimeters per meter squared. Next slide. And then this is getting back to the, do we really want to wait for symptoms or not? Those that waited for symptoms are in red, and the asymptomatic patients with the other were in the blue line at the top. Again, survival on the y-axis and years out on the x. Next slide. And this, I hesitate to comment because this is from Dr. Desai's. This is Dr. Desai's paper, but from the Cleveland Clinic, to close it out, next slide. They looked at, they had 484 patients that did not have surgery, had 933 that did get surgery. And if you did get surgery, and these are patients with severe AI, most of them were asymptomatic. They did, or minimal symptoms, they did better. And you can barely see behind the red line is a normal age, gender matched survival curve. So you return patients to their normal survival if you do operate on them versus those that did not achieve surgery. And then they, next slide. They also, this is a group of patients, the patients that did not get surgery, and maybe Dr. Desai can comment further, but they noticed again, starting at, here's centimeters, not 20 millimeters, but 2 centimeters per meter squared, they start to notice a mortality penalty waiting, or for the patients when the ventricular dimensions started getting bigger. And those are my 3 centers. So Mayo Clinic, Cleveland Clinic in Belgium, all showing that maybe these classic guidelines waiting till 2.5 centimeters per meter squared may not be the right way to go. Even though it seems like a lot of cardiologists are waiting for symptoms. That's pretty much what I see in my practice as well. And I think that's the last slide. Thanks.
Well, I think that was a tremendous tour de force of everything you wanted to know about aortic regurgitation in a very compressed period of time. So I hope you were closely listening and taking it all in. But I think to summarize here, the large group of us ultimately can come around to the conclusion that we are doing our patients a disservice by waiting too long to refer. So I think at the end of the day that there's something that we can clearly take home from this. It's that early referral is critical. So I think that brings a number of questions, and I think it was alluded to. But at the end of the day, what do you think about, are we ready as a field to move to volumes, and why haven't we, so to speak, to date? And so open this up to the floor for people to sort of comment on what the respective value is. Obviously, we've seen a lot of literature to suggest that volumes may be superior in identifying those who are remodeling. So why not now? And what do you do in your practice to try to make the volumes more reproducible?
Who wants to go first? I can go for it. I think it's a no-brainer.
Dr. Desai,
It
how
should
are
be
you?
volumes. It should be volumes. More importantly, indexed volumes. And I'm going to push the envelope even a little more. In this day and age of, terzepatides and semaglutides, BSA has gotten rapidly shifty. So in fact, I would say in our practice, not necessarily for AR, but say for aortopathies, we resort to indexing height because that is something that doesn't change. So, volumes, I think, and some level of indexing that needs to happen. For sure, there is no doubt about that because just diameters alone, and often, as all of us know, the aortic regurgitant heart tends to remodel in a globular way compared to an ischemic cardiomyopathy heart. And echocardiography, all of us are multimodality imagers, the difference between 5.7 centimeters and 5.9 can be very, very dicey at times. I'll stop here.
Absolutely, and I think it's interesting also, there's some data on echo to suggest that if you measure in the mid ventricular dimension, that in fact there's a better a closer correlation with cardiac MRI volumes as well. So the question comes up, not only should we use volumes, and I would agree we should use volumes, but if we're even within the linear measurements, what's the best way to measure it and what's the best way to index it? So all really good points. Dr. Shu, how do you think about this?
Yeah, good question. Yeah, this is a good question because it's an issue in our institution. My institution doesn't regularly use MRI, but I agree in this situation, MRI is really a no-brainer. If you're trying to measure asymmetric remodeling, how are you addressing this if you just have a linear dimension? 2D echo is not great at measuring LV volumes. So what we tend to do is that we use 3D transthoracic echo. From time to time, we use this cutoff of LV end systolic volume of 45 milliliters per meter squared as supportive as with moving forward with MRI to get a more accurate measurement.
And Dr. Bieber, in your practice, when you are referred a patient that may, for example, have dilation by linear measurements, but when you do the volumetric measurements, it's non-dilated, or vice versa, how do you think about those sort of discordant cases and integrate that with the patient in front of you?
Yeah, I think we try to order MRIs, but I don't know what I heard Dr. Zhu's comment that it's not a big part of our practice, but sometimes it's a little bit of a waiting. We have a little bit. It's not as easy to order an MRI, at least at our center, even though I would love to have that ability. We order them, but and we do try to incorporate them in those kind of borderline cases. But I'm kind of envious of your center and maybe Dr. Desai's, where you have maybe they're more readily available. But I do think that we need to start moving that way.
Mm-hmm. I mean, an important thing is, if you are, at least this is how I think about it. If you suspect there's severe AR, and if your LV is bona fide not dilated on echo, 2D echo, 3D echo, generally for chronic severe AR, you need to have LV dilation to go hand in hand. So to me, yes, we order a reasonable amount of MRIs, but it's not a deal. More often than not, I end up ordering MRIs when I've decided to sit and wait on a patient, as opposed to, the ones that are clear, severe AR, dilated LV, not much song and dance there. We see a fair number of those patients. I don't need an MRI on every AR patient.
So to build on that a little bit, obviously a lot of people don't have access to MRI, and I think that is a major limitation here. Using the echo, are there high risk findings that you would to suggest that even if you don't have MRI in your area or in your local, that person absolutely should have it. So, for example, a dilated LV with quote unquote moderate aortic regurgitation. How do you think about those individuals?
Again, look, if in that context, at least this is how I think about it, is as follows. If there's moderate AR, if it's an eccentric jet of AR, I need to confirm that it is indeed moderate. And that's when I would probably be inclined to order a TE for a much better look at that. If it is truly moderate AR, but a dilated LV, then you have to think about two possible etiologies going on. Patient could theoretically have a non-ischemic cardiomyopathy and or an aortopathy, and then they, I've seen multiple patients where you have moderate AR in the setting of a non-ischemic cardiomyopathy. The last thing you want to do is try to fix the aortic valve once you're confirmed that it is not severe, because the LV function may or may not improve. So that's one scenario you have to think about also.
How do we think about the mixed valve disease population? Obviously, a whole different beast all unto itself. But Dr. Beaver, do you see somebody with moderate AS and moderate AR? There's some data suggests that their outcomes are similar to that of severe. Do you use that as an indication that patient should be operated?
Yeah, I did one this morning. So yes, so moderate AS, moderate AI. Yeah, I mean, so I think that those patients need to get taken care of. And I know the Cleveland Clinic does aortic valve repair. We see a lot of we're a huge center for aortic disease, so we're always trying to spare the valve. So I guess what I'm saying is your surgical options in 2025. The valves are much better than they were before. I mean, the Edwards Inspiris valve now out to 8, soon to be published, probably 10 years and a year or two from now. That's an excellent valve. The mechanical valve, the Onyx valve now has a lower INR for your younger patients. And then if we can repair the valves, we're repairing them.
Are there other metrics that we haven't mentioned on imaging that are helpful to you in receiving a patient to know that maybe this is a bit more severe, or then maybe this is a little less severe? And specifically, I want to address actually one of the comments that was made in the Q&A, which was about the LV stroke volume to RV OT-VTI ratio in determining the severity of AR. Does that have value to the group, and does that have value as the person receiving that patient and considering surgery or are there other metrics that are arising that may provide some sort of more integrative value in terms of assessing the severity of disease?
Yeah, I've not used that myself a lot, but I think if you have an echo and then if we're not seeing what we need to see, if we go to a TE just to provide a little another level of evidence, it's the AI is significant. But I've not particularly used that ratio, and maybe Dr. Desai or Dr. Zhu can comment.
Go ahead, Dr. Zhu.
Sure. So to answer your question about mixed valve disease and multiple jets, I actually find TEE-derived 3D contracted area to be very helpful. As I mentioned, in my institution, because of our limited availability for MRI, we do a lot of TEEs, and I routinely find myself measuring this. It's less dependent on jet eccentricity and driving pressures, and the orifice area is often elliptical in shape, and so having this additional 3D measurement to add is very helpful. I know that the cutoffs for severity are not so clear, but from a surgical perspective, I also find it to be really nicely isolating where the regurgitant jet is coming from and guiding surgical intervention.
And look, what would be echocardiography without a new formula, right? So this RVOT-VTI to LV stroke volume ratio, yeah, if I'm mistaken, Jordy, correct me, but it's like 5.5 or 5.7 is the ratio that, there's always ratios that you have to remember. But, well, I think, the way I think about these things is rather than underestimate and deprive somebody of a procedure or overestimate and unnecessarily send somebody for a procedure, it's all, you can never have too many measurements. When in doubt, question yourself and do more measurements, I suppose. I think so. I mean, this RVOT, because see, what inherently happens is the RVOT VTI, it takes assuming there's no shunt, none of that song and dance going on, you take a completely separate chamber where you're doing independent measurement, and then you are utilizing it to create a ratio. So yes, I think it should be utilized too. But again, one thing I mentioned about the CMR, it is important. Look, if you have eccentric aortic jet with those eddy currents going on, and if you have a dilated eccentric aortic root in the setting of most commonly bicuspid aortic valve, we have measurements that are way off. The echo shows severe or suspected severe, and the MR only shows moderate. What do you do in that? If the echo is convinced it is severe, but MR says moderate, I still rely on echo. I would not deprive that patient of a surgical procedure, because we've seen multiple scenarios where either the technologist made an error in phase contrast measurement, or because of the swirling eccentric jets and the translation motion, you may have some erroneous measurement. So I think at the end of the day, you have to collect the totality of evidence for the patient in front of you.
100%. And I as a cardiac MRI reader, often refer back to the echo and say, what did the echo show? Because they're complementary sources of information. And obviously, the more information we collect, the better at the end of the day. I think one of the ways that I sort of integrate VTI into my practice is if there's a high VTI, LVOT VTI, particularly in a setting where there is no other clear reason for that VTI to be high. There's not, the cardiac output is not especially increased or et cetera. Then that's a suspicion that there may be something else going on, that there may be some more severe AR than we're actually alluding to or being able to capture visually. But as a sort of cutoff rule to say this ratio happens to be a sign of severe AR, we don't currently use that in our existing practice. So I think at that point in time, if I'm really scratching for straws, I would refer certainly for a cardiac MRI to be able to help clarify it further. I think we have a couple of minutes left. Just I guess a couple of concluding comments from each one of you. What would you think of what you want the larger group to take home at the end of the day? If you have one or two concluding points. Whoever wants to start, Dr. Shu.
My concluding point is, we're interviewing too late, and there's a gender difference in aortic regurgitation, and I would advocate for more studies to look at women in their cohorts.
Dr. Tsai?
Yeah, I agree. I think, we've long recognized that the guidelines, the data that drove the guideline recommendations were based on in times before my time in medical school, kind of a thing. So they need to be updated. And I think, indexed volumetric index measurement that is sex specific, I think is absolutely important. And when in doubt, incorporate multimodality imaging. Don't just rely on one or the other.
Perfect. Dr. Beater?
Yeah, I think we're referring too late. And I tried to, pick out the couple papers from major centers around the world that shows that, based on our current guidelines, there's probably a mortality penalty there. And, it's hard. We're so used to being referred on symptoms, but we're probably referring too late.
Yeah, and I would echo that, so to speak. going forward. I think you've heard loud and clear that this is a progressive disease process and ultimately can cause a substantial amount of LV remodeling and dysfunction. So referring early and then having that patient in practice so you can follow them over time progressively to make sure that their LV is not further dilating, I think is a really critical part of this. So thank you all, and we'll turn it over to Mr. Romeo.
Thank you very much. Yeah, it was a very stimulating conversation, exchange of ideas. I want to thank all of the panelists for their participation. I also want to thank Edwards Life Sciences. And with that, we'll bring this to a close. But thanks again. Have a good evening.
Thank you so much.
Bye-bye.